Yeah, so let's dig a little bit more deeply into insulin resistance specifically, and I'm going to use sort of my again using a car sort of or a traffic network type analogy, and then we're going to get to the root cause of what are some of these things that cause the insulin dysfunction. And I'm focusing for a moment on carbohydrates since that can be predominant macronutrient in excess that drives insulin resistance. So in my work, I kind of describe that carbohydrate or glucose molecule like a car, and there's three major parking lots. You've got your muscle, liver, and fat. And really, in an ideal metabolism, our muscle parking lot should be clearing about 80% of that incoming glucose traffic. Basically, the glucose goes to that muscle parking lot. It causes an increase in insulin. Insulin opens the gate, and that glucose gets inside that muscle. So really, that's an optimal metabolism, is when the muscle is doing the lion's share of clearing glucose from the blood. Now, what happens is when the muscle, for various reasons, which we'll talk about, when it starts to actually not respond to that signal, what happens is we develop insulin resistance. So if insulin is the parking pass, the muscle attendant, the gate guy is basically trying to, put the pass inside, but the muscle's not responding. So now we have this overflow glucose traffic, and that can go in various directions. So let's start off with the liver parking lot. The liver parking lot does have fixed limited space to hold that glucose, and the storage form of glucose is glycogen. So typically about 100 grams of glycogen in the liver. When the liver runs out of that space, that overflow glucose goes through a pathway we call DNL, or de novo lipogenesis. And that's basically the conversion of glucose into fats. And the problem is, even long before you've developed a commonly known condition as fatty liver, when you start to microscopically develop more fat droplets inside the liver, those tiny fat molecules can interrupt insulin's normal action. And in the liver, what that basically means is your liver is going to be pouring out more glucose than your body needs. It's going to increase a process called gluconeogenesis. So that's excess glucose traffic that's been directed into the liver, which produces that extra fat and then expels extra glucose, and also expels along with that triglycerides, which is a storage form of fat inside the liver as well. You've also got overflow traffic that's going to our fat cells. And I kind of joke that, your muscle has got fixed limited parking space. So that parking lot has limited space. Your fat cells, that fat parking lot has unlimited parking space. It's open 24/7, right? So you can get hundreds of pounds of body fat from that diverted traffic going in that direction. And that's what can lead to increased visceral abdominal fat along with subcutaneous fat as well. So I want you to visualize that situation, because that's going to tell you what are your individual risks and manifestations for insulin resistance. For example, some individuals might just have elevated waist circumference. So visualize that means most of the glucose traffic is going towards that fat parking lot. But maybe it's not overwhelming the liver too much yet, which is why you may not yet have elevated blood sugar, elevated triglycerides. Other individuals, interestingly, I see that very little traffic is going towards the fat cells, maybe just enough to add an inch or two along the belly, but most of it is going towards the liver. And that's generating a lot of triglycerides and a lot of glucose if it looks like that's interrupting the insulin signal. So that could be our slender, relatively slender individuals who don't have much diversion to fat, but most of the damage is happening at the liver level. So that's the other pathway. Now, when you think about insulin transduction, it's kind of like a circuit, so insulin basically attaches to the cells and it sends a lot of downstream signals to allow your body to clear glucose. If you were to look at three categories of areas that interrupt that circuit the most, I would basically say number one would be inflammation. So excess cytokines, which are the inflammatory chemicals in the body. The second is hyperinsulinemia, so having excess insulin in the blood. So when your muscle cells are not responding to that insulin parking pass, the body responds by overproducing insulin. And that excess insulin will feedback inhibit insulin's normal signaling pathway. And the third thing is those toxic fats that I talked about. There's words for that. We call them diacylglycerol or ceramides. Those can also short circuit that insulin signaling pathway. So to remember this for you practitioners out there, people listening, I say three things. It's cytokinemia, it's hyperinsulinemia, and it's toxic dyslipidemia. If you can think of those three categories, those are central factors that can really interrupt that insulin signaling mechanism. So then for some people, if it's just hyperinsulinemia, that's the predominant factor. If you focus on lowering those excess carbohydrates and exercising, doing intermittent fasting, Maybe you're going to wear a CGM and keep track of your glucose response. Even though you can't measure insulin, when you're really contracting those glucose spikes and controlling that, the hyperinsulinemia might be controlled, and that might be sufficient to reverse that insulin resistance. There's other individuals that don't show signs of hyperinsulinemia, but it's all coming from cytokinemia. So it's coming from chronic inflammation, which can be from a chronic infection, from emotional stress, an inflammatory diet. So that's the other element we think of. And then that dyslipidemia, again, that can be a downstream product of any of those interacting in the wrong way. So I'm simplifying it by saying three categories. But as you know, these are always overlapping. Hyperinsulinemia drives inflammation. Increased inflammation drives insulin resistance and hyperinsulinemia. But those are categorically the three ways I think about it. And then with each patient, I try to decide where is the area that we can make the most impact initially. If they've got elevated blood markers for inflammation, HSC reactive protein, maybe we're going to attack inflammation first through an anti-inflammatory diet and other mechanisms. If it looks like they got a lot of high triglycerides or elevated blood sugar, and they're clearly from a dietary intake consuming too many carbohydrates and calories, we might attack it from a dietary standpoint. So sorry, that was